I think we should go ahead and start orienting folks to the workshop, just since I'm sure there'll be some people scooting right over from something else since we're all online. I'm Lindsay Zimmerman. Tom Rust is the one wearing the sharp glasses that I haven't seen before.
Hi,
They look
everyone.
good.
Thanks.
We're going to both cover the material sort of back and forth throughout, and this is just 1 hour. So it really will just be an intro to how we've used these methods and what we think are helpful to think through. Let's see, let me try to not advance things that fast. Tom and I work with an amazing group of scientists and an even larger array of partners nationally in the VA, and I'll thank everybody at the end. But together we call ourselves Participatory System Dynamics, and we're going to spend some time kind of going back and forth today between the early participatory approach that we took to where we are now trying to scale a participatory approach. So you'll get a sense of sort of the early in the modeling project versus later. And I wanted to quickly toggle out of the slide deck and just show the packet real quick. Can folks tell me if you're seeing it?
Mm-hmm.
Okay,
Yes.
Thanks everybody. So this I put together just in case you want to jot some thoughts to yourself. We do this at a mixed methods workshop I teach at Stanford, where you just kind of are going through and jotting notes to yourself, and I thought that would be really helpful. So if you get by this one-page description of what we're doing here, and you'll see this page where if you want to follow up with this and use our demonstration simulation and guides and everything, there's information about doing that. But starting here, where it says workbook, we're going to ask these questions as we go, talk about them with you all aligned with our learning objectives, and you can type in the boxes and add your own thoughts about where you may be thinking through using this approach. All right, and again, if you just joined us, that file, that PDF was emailed out if we had your email from the conference committee, and otherwise it's in the chat. All right, Tom, let me try to get the
Great.
right file back up and pass it back.
Yeah, so that worksheet that Lindsay was just showing you asked you to consider 9 questions about your own PSD modeling project. And to correspond with the worksheet, we've organized this workshop into the same 9 questions, and we'll pause for about 5 minutes after each learning objective to answer what questions you have related to that objective.
Yeah, so if you really hear the question and have one that you want to get top of mind, then we'll pause basically at 1/3, 2/3, and then at the end to collect and discuss some questions for about 5 minutes each time. So learning objective 1 is to describe how stakeholders are engaged throughout a modeling project. And to think about that for folks at this meeting, I think a really key insight for those who haven't heard this before is that models are designed in the system dynamics tradition to represent the implementation problem, not the solution. In fact, what you're doing is iterating in co-defining the problem and then over time using that model of the problem to work with stakeholders and identify a solution. So the first thing I would consider for everyone here is to really get clear about the primary implementation outcome that you're focused on and how you might use modeling to define that together over time to refine a working definition of that problem. In our case, we were focused on evidence-based practice reach in the VA, but you may be focused on adoption or another problem. We started with the reach of evidence-based psychotherapies and pharmacotherapies in the VA because we really didn't understand why so few veterans who were already engaged in care weren't getting our highest quality practice. It was sort of confusing because of all the infrastructure that was already available. So to refine our working definition of our implementation problem, we had a context in the Veterans Health Administration where we were fully in the active implementation phase. We had all of this infrastructure to institutionalize the delivery of evidence-based practices in our project. So the VA had national training programs that had already been going on for almost 10 years, enterprise-wide quality measures that were incentivized in public, clinical practice guidelines and mandates, the electronic health record system, care mapped to population in these multidisciplinary care teams. And yet still, we were reaching about 1 out of 3 of our patients with our EBPs. And again, these were the most common cognitive behavioral therapy for depression, medication-assisted therapy for opioid use disorder, very well-established evidence-based practices. So our limited EBP reach problem really came out of thinking through why we were reaching so few folks, why at the active implementation phase, if you think about this in like an Aaron's EPIS framework, we were not reaching any more folks. And also, we had a lot of information already from our stakeholders about what they saw as the barriers and facilitators. And many of the EBP trained providers would describe system factors interfering with reaching a greater proportion of their patients.
So another key question early in the modeling project is to ask who should be engaged to further refine and co-define the implementation problem, and also to think through how are you going to do that. So for us, in our experience, models that are co-created with several different groups of stakeholders really help to build consensus and a more complete understanding of the problem that you're trying to solve. So it's important to prioritize modeling exercises from the beginning to understand your implementation problem in terms of the interconnections between variables, between perspectives, and trends over time. So altogether, we call those the system dynamics of those would be the system dynamics of your EBP implementation problem. So to improve the feasibility of any modeling project, you've got to consider what you already know about the implementation context. And maybe you have preliminary qualitative or quantitative data about your problem. But as important as that is, and as helpful as that is, prioritizing elicitation of stakeholders' mental models using system dynamic scripts, now at the beginning, before you do any other interviewing, is a really efficient way to begin to conceptualize the problem. And it's helpful because you're not just eliciting factors without considering how they influence one another, but you're really starting to see the whole picture and how all those pieces and perspectives fit together.
Yeah, so if you already have a lot of great, rich qualitative and quantitative data from your stakeholders, awesome. But if you haven't done anything at all, as we'll show, group model building scripts are a great way to start eliciting the information in system dynamics terms from the beginning. Later in the modeling project, we really work in a participatory way on purpose so that we can clarify iteratively rather than decide up front whose decisions the modeling will support. So we're really listening to stakeholders to try to understand, of all those who have a stake in this problem that the model will represent, who has the unmet need, or I'm fond of saying whose decisions need upgrading. And I think it's important for people who are framing their problem to consider that you might have a much larger array of stakeholders involved in the model development and validation than will actually use your modeling outputs in an ongoing way. So in the end, although all of these partners are involved with us, as Tom described, and have been now for 5 years, we are specifically focusing on the front line as the unmet need. And that was something that we iteratively got to together, working with all those stakeholders. So we worked with patients, providers, policymakers, and really tried to develop an effective partnership based on trust and better understanding of what really the pain points were. And over time, together, we decided that it was the expertise of frontline staff, those who make EBP-related decisions all day, every day, that really didn't have the support, didn't really have a way to look at the problems in relationship to their local resources. And so the level of decision making that we wanted the models to support was all of those EBP decisions that people were often making real quickly using their heuristics and rule of thumb. And so this is just something I put together from the book by Peter Hubman. If you have the 2014 book, you'll see a version of this table, and then Jonathan Scotcha as well, where at the team level, we're thinking in general about modeling as like the general capacities for learning and coordination that the teams have, the ability to resolve some conflicts through modeling and achieve greater consensus, but also the formal capacity of the models mathematically to analyze the local resources and to make sure that the strategies work and make sense. In our case, for example, we have particular strengths with finding solutions that work within local staff time, the existing EBP-related resources that are in the setting, which staff, and it turns out all the way up to central office in our healthcare system, are equally interested in knowing when teams are doing the best they can within the resources they have to work with. So we wanted to pause there, and we have sort of considered 3 questions so far, which is, what is your implementation problem that you might think this approach could be targeting? And who do you think should be engaged, and how are you making those decisions? And do you already have an insight at all about who might need decision-making support that maybe currently doesn't have the resources? Is there anybody on the call who has some thoughts or questions related to these first objectives they want to run by the group? You're literally doing the strokey beard thing, which makes me want to ask what you're thinking about. But that's, I don't want to put. Who has a question or a thought?
Where do you think you're going?
I have a question about dealing with turnover.
Yeah.
I assume when you're talking about, who needs decision-making support, it's it's not a specific provider, it's like frontline providers, right? Like it's a group of stakeholders, not specifically designated stakeholders. But when you're collecting this data around, defining the implementation problem, and really valuing the perspective of these multiple groups, which I think is super important, how do you account for the fact that, whatever your problem that you're coming up with, and then ultimately the support that you provide for decision making is going to be within the context of, the sort of constant evolving of, the target of that decision making support. Does that make sense? I feel like it's probably a problem we've all dealt with. So.
Yeah, it sounds like, let me take a stab at it and see if I'm missing something important. It sounds like you're talking about, hey, we build these partnerships, get the stakeholders together, and in most of our implementation contexts, there's a constant churn of people that changes over time. And so how do you think through building these things in a way that could be sustained given how common turnover is? Am I getting it?
Yeah, you described it much better than I did.
I
You
appreciate you brainstorming and thinking about that. Yeah, well, I'll just give you a sense of a few thoughts I have about that. I think it is an advantage, and we're going to talk about this more throughout the workshop, of system dynamics, that you are thinking of, in our case, our modeling activities are targeting a level of teams that sort of persist in time, even if the staff members change. So we definitely dealt with turnover a lot in our efforts in some sites. We have had teams explicitly use modeling to plan for or address being short-staffed. So much so as this being a way to address this problem that the Deputy Undersecretary for Health in the VA created a memo where VAs who are struggling to fill mental health staffing positions are either they're supposed to report to Congress about their improvements in the staffing, or they're supposed to be working with us to do the best they can with the staffing that they have. So the idea that we're conserving that staff EBP-related time in our models can actually be kind of empowering for staff who might be feeling kind of burned out and frustrated by the turnover, because the care settings persist, the teams delivering care in those settings persist even as people turn over. And the resources actually do help them try to think that through concretely and formally, which we'll definitely talk about as we go through the workshop. Is there something else you would add about this question, Tom? Some other way you're thinking about it?
Maybe that the we'll get to this as well in the rest of the talk, but that the simulation that you come up with should be flexible enough that as staff change and their particular problem changes maybe, or they're just going from having 5 therapists to 3 therapists or something like that, their context changes, the simulation should be flexible enough to still provide them with insights.
Yes, and we'll definitely talk about that.
As staff change, yeah, it shouldn't be a deal breaker.
Yeah, I think showing might be better than telling, Hannah, in terms of trying to get at that. But thank you so much for asking the first question. We'll keep going through and move on to our second learning objective, pause again for questions, and just keep fleshing this out and thinking this through together.
May I ask a question?
Sure. We may come back to it, Reza, at the end, but please do get it on the list.
Yeah, so I just posed my question. If you think you want to answer it later, it's fine. So again, I have been thinking about this for a while. The first objective here is a problem, not an innovation. So basically the starting point of this process is probably different from the starting point of implementation science, that like you have an innovation, you're going to put it in practice, then you think about solutions. So my question, like basically my confusion here is like how you're going to address the multiplicity of interventions to address a certain problem that is the starting point of this practice, because the funder and everybody else is interested in single intervention, and then you may come up with a whole constellation of different, I don't know, like knobs and potential interventions that may affect the outcome of interest. So basically the question is about the discrepancy between the starting points of implementation endeavor and this group model building process or system dynamic process.
Yeah, so maybe I will take 1 minute to tease what I know is coming in response to that, and then we'll do a more thorough treatment of the question. It's definitely the case that starting with this as a process of further refining the problem in terms of like the argument in the grant, I think you're going to be on stronger footing with the participatory and community-based side of this tradition in the idea of engaging stakeholders than you will be with people who do start with like, I've got an EBP and I've got to get it out. I think that just the second comment though I would make, it's not just participatory, it's not just system dynamics. What I find is that when you do define the problem in more complex terms than people are used to, you're putting those things together, then it becomes less of a problem because we've been funded twice through the dissemination, implementation, research, and health study section at NIH, and in both cases we argued we had a very strong evidence base for our practices. We had very strong evidence of a gap in terms of EBP reach. We had a lot of stakeholders who felt that these tools better matched the complexity of what they needed to address their implementation challenges, but we were in the active implementation phase. And so it really didn't seem to me like a hard sell to say EBP-related decision-making is complex, and so we need resources that match that kind of problem. Defining the problem in a system way helps you keep more stakeholders at the table, if I just kind of close that loop, because then you don't lose people for whom this is the thing they care about most, and this is because probably they actually are related to one another. And I think as we go through, we'll talk a little bit more about that. It's a great question.
All right. So learning objective 2 here is to understand how modeling exercises elicit stakeholders' mental models and then formalize them into simulation models.
Sorry, Tom, didn't respond to my click. There you go.
So we talked about the about Scriptopedia, the group model building script library before. The key questions there, if you're going to use it, are who will participate, in what roles during the modeling session, who's the facilitator, who's the modeler, what are the roles of the stakeholders, and have you identified a feasible strategy for exploring stakeholder convergence and divergence? Because they're definitely not all going to be of one mind, at least not at the outset. So we recommend highly using Scriptopedia. It's a well-used, well-referenced group model building set of scripts that have been established and modified and improved over decades in system dynamics. For our example, we found them highly efficient, and the one that I think we probably want to talk with you most about is called Graphs Over Time. You can find it here in the Scriptopedia that Lindsay's showing. It's basically you start your stakeholders with a blank sheet of paper and then elicit their understanding of trends in the key variables that they're dealing with that are part of their problem. So it's a very participatory approach. It really builds co-ownership of the modeling process and the outputs. And it starts out really simply. You can, I mean, our initial prompting question was, how does a veteran's need get met around here? And then ask some follow-up questions about, well, what happens before that? What happens after that? How does that change over time, et cetera? So now, for us and following this process, the stakeholders put a lot of time into model development, but that approach yielded a model that pretty much perfectly matched their needs and their context. Now, that's not the only way to do it. In system dynamics, there's been an example around for about 50 years that's at the total other end of the spectrum. Consultants and educators have been running this exercise called the beer game, really for about 50 years. It's been around for a long time. And this standard exercise is used all over the world. And the key insights that you get out of it as a participant are how easy it is to make decisions that make problems worse when you don't understand the fundamental dynamics of the system that you're in. And it also helps participants realize that the same common system behaviors are a result of their own inability to deal with the dimension of time in their problem. So that's what I'm talking about. There are any delays that they have between when they make a decision and when the effects of that decision are realized can cause accumulation, and humans are just really bad at taking that into account. So there's, in those examples, there's no, or in those exercises, there's no development cost to the learners, and they definitely have some aha moments in learning that comes out of it, but there's also no tailoring to the specific problem that each of the participants has either.
Yeah, so I see, thank you, Tom, and I didn't mean to rush you there. I would say just about using Scriptopedia, some of you on this call, I know I have pointed to going here to use these scripts. It is really makes a lot of sense if you're trying to use these methods to implementation science reviewers at, for example, I sit on the query review panel in VA, and anytime that you can say, this has been really well established in a discipline related to organizational change management for 50 years, 30 years, 40 years, huge empirical basis, and I'm just taking it off the shelf and applying it to my problem, I would really recommend you to start here. And of course, if you get system dynamics reviewers, they'll wonder why you didn't start here if you're familiar with the tradition. And I see Hannah's question about the time commitment required for the process. And I think that in a true participant, I'm going to partially answer the question and keep going and continue to answer the question throughout if I can, Hannah. I think that like a good participatory partnership, it's not something that happens one time and is the end all be all. It's sort of like you keep recommitting to one another over time based on your series of small wins. And so paradoxically, even though it seemed like we were spending a lot of extra time iterating with partners until we were sure all perspectives were included, which feels like a really time and laborious thing at first, paradoxically, our progress just ratcheted right up, and the traction and accelerated, you know, resources and partners and participation that we got just increased and increased. And I think it was because we were going about it in a way that was thinking about time constraints every step of the way, which we're going to talk about a lot for the kind of remainder of the workshop. So forgive that partial answer. We'll answer it more. So this is the fourth question to consider. So what is the level of aggregation? This is a really fundamental idea in system dynamics modeling. Often, I think people in the implementation science world think in a social ecological model kind of way, or think about sort of layers of an organization. And that's what the example here sort of implies, that it's providers, teams, clinics, hospitals, and so forth. But I think, as we're going to keep going to say, it's also about, okay, so who needs to be at the table? What level of data do we have to support what level of decision making? Because if you look at these stakeholders, providers make decisions about EBPs, teams coordinate EBP delivery over time, clinics, hospitals, healthcare systems, each have different levels of decision making, understanding of what might be related to EBPs. So we sort of start with the idea that none of those stakeholders have an incorrect view. We just on our own have an incomplete view. And the modeling exercises are eliciting more and more expertise until we've identified the core synthetic set of ideas that have to be in the models. For us, we still started getting closer and closer to the decisions that EBP implementers make all day, every day. So at the end of the day, it is not a policymaker with a budget who decides whether a patient starts or stops an EBP, or whether they refer, or whether they, you know, keep the patient engaged throughout care. And on the screen here, you're seeing a Teams question. They wanted to know how they could get more of their patients through a full course of psychotherapy when they start. So the when they start is, if you can see my mouse work, I'm not sure if you can on screen, where it says patients in their first 3 months of psychotherapy. So the stocks here are aggregating to accumulate the state of care that patients are in, the state of this EBP. Now, psychotherapy may be familiar to a lot of you because it requires return visits, usually weekly psychotherapy, maybe up to 12 visits. But having worked with mentees in the TITRE program and so forth, I know that care continuity to meet a patient need, keeping the patient engaged over time across screening risks or whatever the follow-up or need may be, is really common clinical care delivery problem. And so the key here is, what is the appropriate level of accumulation of patients? In this case, we thought, working with stakeholders, that the first real state was people who start and they get that first visit of an EBP, but they don't actually sort of flow on to be engaged for 2, 3, 4, 5, 6 sessions. And based on our evidence-based psychotherapy literature, we knew that this middle state of care also was important, because patients who have a good early evidence-based psychotherapy experience, even if they don't complete then, are more likely to ultimately come back in and complete a full evidence-based course of care to meet their need. So the system dynamics modeling helps stakeholders to determine these kinds of structures in their problem, or to think them through. And on the left-hand side, you can see some data, and you can see that red means that the model is being parameterized with these local data stores. So the models represent the EBP implementation problem as the accumulation of stakeholders' aggregate decision-making over time. And the level of aggregation in the modeling is designed to be really concrete at the level of people who make those decisions. So you can see that we have our starters, initiators, and completers, 3 states of care that describe this pattern of engagement, and that all of those states can be determined from local team data. These are sources of data that are consistent across all of our settings, and we'll talk about that later. Stakeholders typically will converge and diverge in their understanding of the problem, but we definitely got to a point where we realized this could represent an evidence-based psychotherapy for any team, anywhere. But the actual values in these states of care are going to be totally locally specific. And for this team, their highest leverage change is going to come from where most of the patients are accumulating, that state of care. In this case, for this team, it's the middle stock. in any given week, they're serving 21 patients who are in sessions 2 to 7 of their therapy. And as the stakeholders started to kind of like converge around these models and we got to these more formal models, they started trying to understand how these dynamics explain what they're seeing locally. And so this team is getting the insight that they may be starting new patients about 3 per week, and they're pretty much getting through that first visit. They're keeping most of them into visit 2 or 3. In fact, about 79% of the patients who start make it to visits 2 through 7 in their first 3 months. But this team found that only about 40% were actually moving on to complete. And that's also over here in the data. But without a picture, oops, sorry, over here on the data on the left-hand side, the initiators who complete is less than half. But they didn't really have a causal structure to help them understand why. And we went on with this team to target our resources toward where they were accumulating patients in care and where they were falling out of care.
Yeah, so I saw this question in the chat actually too about simulation versus just diagramming. And really, I think, so we definitely do both with groups, and we'll get into how we divide up our time between those two in a bit. But I mean, diagramming the problem explicitly with the stocks and flow structures and the causal loop diagramming is critical. So, and your primary goal here is through this process, working with the teams and your stakeholders, is to achieve saturation. So akin to saturation across stakeholder interviews or themes in qualitative coding. And this is saturation about the causal dynamics of the implementation problem. And causal loops are diagrammed with the goal of using them to explain the key system behaviors that the team thinks are responsible for their EBP implementation problem. So in the example that Lindsay was just talking about, these system behaviors are not only about the problem. They're not just about the reach of EBPs, but we're going to be able to use the diagramming to zoom in or out on trade-offs that the team is facing, such as referrals into EBPs, the graduation rate, just like Lindsay was talking about, of EBPs, or trade-offs between initiation, patients initiating EBPs versus how much effort the team is putting into those patients completing those EBPs, right? Because the team only has a limited amount of time, and they probably don't know what the best way is for them to spend their time. Should they be focusing on initiation? Should they be focusing on completion or graduating or getting more patients into their clinic? They're probably trying to do it all. So we went through this process with the teams, and at the same time, we're also thinking about establishing the validity of the models. So using the models, the methods described here in this figure, which is by Barless, and you can download it from mtl.how, and you can also look at all the models that we created with our teams, not just us, right, but with our teams. You can look at the under the hood models and play with them in Vensim PLE. You can download Vensim PLE for free, or if you already have a copy of a paid version, and explore as you want. We try to keep everything as transparent and open science as possible.
Yes, and if you don't want to use the Vensim stuff to see kind of where this started, you can also just go to the demonstration model and see sort of where it is now, which is all the way to the level of you can run it from your smartphone, your Android or iPhone smartphone. Great questions in the chat. I'll just make a comment here before we go on to the next question, Tom. The question, or I'll click to the next question while I answer this other question. The question in the chat was about whether we always go through to simulation. I think we're going to talk a little bit more about what the applied shift in thinking is that we hope stakeholders will get from learning from modeling. And I have to tell you, I think causal loop diagramming is really, really important, and I don't want to say something too controversial here. I think that the promise of being able to run simulations at the point of care was a big part of why stakeholders were excited to do this. It wasn't to come up with another form of mapping. because I think, for example, some of the literature that's out there, you might wonder what's the added value of conceptualizing your problems in a causal loop diagram as compared to an intervention map or a concept map or any other process map. And I do think that much like if you've ever run an online calendar to find out when you're going to pay off a debt or where you're likely to be in the future with your waist size for back when we went to weddings for a summer dress, or really any goal that you've tried to, you know what the variables are and you want to know what adjusting decisions related to those variables, what that will add up to at some future point in time. I mean, that is really, really valuable to frontline staff, especially if it is dynamic and updates as things change, and helps them really manage their day-to-day. You want it to be moving quick and fast. So I do think that the simulation offers some real advantages, but obviously using some of those earlier scripts is a key step in the process. So
And
Tom,
as
go ahead.
much of a proponent of simulation as I can possibly be, I have definitely learned through working with frontline teams and going through these different projects with people that starting with the simulation is also an easy way to lose people. And so in our process now, we spend a lot of time working with people just on the diagrams, and as we'll get to, their personal sort of team context, and really trying to build that partnership with them so they understand where we're coming from, and build that faith that the simulation is actually going to tell them something real that reflects their own context. And we really have to do that, put that time in with their data and also with the causal loop diagram before we can do anything automated, any kind of simulation work, to have it really stick.
I think also, as you
yeah.
move on to this, Tom, I think I'm just going to speed us up a titch because we're answering questions as we go rather than pausing for 5 minutes every third, which is fine. But we'll get through questions 6 and 7 here, and then we'll pause one more time for questions.
So data sources. This is an important thing to think about what data sources are common across EBP implementation contexts, and how can you maybe use those, the data that are available, to scale your model to be used in the future. And here we try to think about broad units like staff, dollars, patients, things like that. So here in our example, we used we tried to take exactly those into account. So as you can see here in our data table, this is pulled straight from our simulation interface. We have local staff. It's something we definitely want to keep track of, like who can deliver the EBP, what's the demand, how many patients do they have, how frequently do the patients need to return to the clinic for the EBP. So now we're talking about a variable over time, which is an important one for people to consider that didn't sort of immediately pop to mind when we started eliciting variables from people. No-show rates, engagement durations, things like that. Now, the important thing here in thinking about the scaling up your simulation and making it work across teams, so you put all this effort into building your simulation, you don't want it to just apply to the one team, right? Is that your model can take, even if it's comprised of all these different elements, and it has a common set of variables, each of these variables can take on a local value. So the unique values of each parameter can vary depending on which team you're working with. And the interplay of those variables then, specific now to that team, you can really pull out and show each team how they're using the same identical model. You can show each team how they're unique and how their context is really driving whatever their problem is that they're facing. And that's a really good way to overcome the sort of bounded rationality problems, right? That we don't have the 30,000-foot view all the time, that really constrain decision making and keep it from being optimal.
I want to point out another thing related to the units question here. So what are the units? Definitely helps if you want to build something that your lowest resource clinics could sustain without you, to think about what kind of data are going to be collected and already exist, and they're just sitting there underutilized. And maybe they're not being repurposed to those who are least empowered in your system. But there's so many decisions to think about. That's not just like, in our case, we wanted these to be generalizable outside the VA, so we really focused on a lot of data that is just common procedural terminology. So anybody in the United States who, has to code in CMS codes could use the models, and they could be, since they're all free and open source and online, you could grab them, for example, and try them somewhere else. But there's also decisions, if I can use my mouse work here, about the units. So we spent a lot of time here, and when you start thinking about change over time, we talked to the staff and they said, gosh, there's no typical day in this clinic. So a day was too short. And by the time like a whole month has gone by, it's hard to get clear about how everything is working. But most clinicians felt like they had a very clear sense of a typical week. So in terms of our units, it's not just, are we talking about these are decision makers who make decisions about patients, or who make decisions about appointments, who make decisions about dollars or staffing, but what is their unit of time? That's really important to understand. And some of my mentees over the years have told me that this is a really helpful metaphor for them. I came up with this somewhere along the way, since Tom is the engineer and system dynamicist on this call, and I'm the behavioral scientist and psychologist on the call. This was sort of my first insight that got me jazzed about this as the PI, that your model could be comprised of a completely standardized common set of variables that just take on local values. I have been doing R programming for probably over 10 years now, and this blew my mind for the implementation problem about how do you match what you're doing to the local resources and constraints in the setting. This was sort of like the holy grail in implementation science, was we know context matters. We know not everybody has the same resources. We know these things need to fit within the implementation context, but how do we do that? And so it's sort of like, since these models are all using calculus and are taking on these local values, you could imagine the difference between if I threw, say, a paper plane and a stapler across the room. The equation that would define the state of each of those things, the paper plane and the airplane, in the air, its trajectory, and where it would land, the equation is completely standard, but of course, they're going to take different arcs and land at different points in time in a different place. And so in the same way, by taking those common EBP variables that are in play everywhere, we're able to really get the physics of our implementation problem right. And I think that that is perhaps something that is a level of specificity that many of our stakeholders are hoping for. They want to know that if they work with you to help them, that it will really work. It'll really be helpful and it'll work locally. And this really helps in that way. Okay, question 7. Tom?
Right. So how and when will decision makers interact with your modeling outputs? So let's say you've gone through the project so far that you have a model, you have simulation, you have data, but what do you want them to get out of it? How are they going to interact with it? So for us, just as important as it was to be able to bring in the individual team's context and their individual data to customize the model, to go from here's a generic equation that describes any object flying through the air to here is your object flying through the air. We also needed to customize what teams wanted to get out of spending their time with us. So we had them focus on their own question, develop their own hypothesis, run their own tests, all with their hyperlocal team data. Now they can, this is all guided, but they were in control. So we knew that if we supported the clinical teams, they would also, like, they didn't have infinite time for this. They couldn't, we couldn't do a 3-day corporate retreat or even a half-day workshop, but we had to fit the interaction, so how we and the team and the model all work together into their busy workday. So if we're going to increase the feasibility of participatory learning for modeling with multidisciplinary complex frontline teams, then we have to develop our models and our modeling program to define insights inside basically a typical team huddle. So we had to chunk it down to do as much as we could inside a team huddle and not try to create another meeting or another structure or another way for them to say, well, we don't have time for that.
Yeah, that was really important because most of the literature that we saw not only had folks not taken on the local data and calibrated their model around data that was everywhere while still taking on local values, but it was also the case that people hadn't thought about like scaling the support for using the modeling. So we ruled out the proprietary software packages, for example. We wanted to be able to host it online so everybody could access it. And there were a lot of decisions that we considered about, well, in the VA, we'd had travel bans before due to lack of funding. So we wanted people to be able to do this remotely. During this pandemic, we've had people say, did you think of that from way before COVID-19? And we were like, yeah, we're a national system. And we did. And we knew that some of the lowest resources settings found it the hardest to make it to conferences and so forth. So basically at every stage of the project, as Tom was just talking about, we're tailoring the resources we use, even now that these are sort of kind of slick and more well-developed, to the team's highest priority need. And we, at the level of aggregation again, broke our models down into the types of digestible models that people can learn in a staff meeting, because we knew we were never going to have the retreat or the 5-day workshop approach for people to learn it. We needed them to phase it in or feather it in throughout their ongoing clinical day. And that led us to a suite of models that sort of zoom in on common mental health and addiction care problems. So I would encourage everybody on the call thinking about your project to think about whether your modeling problem can be broken down into smaller chunks or insights about problem dynamics, zooming in or out on the continuum of care, based on not what should be in the model alone, those aggregation unit accumulation, but what your modelers can absorb. How will they be interacting with this in the long run? Is it a C-suite retreat, which is very different than a frontline team at the point of care? Think about how they will actually be modeling or interacting over time. Okay, so I think what I want to do is take one brief question. Reza asks one here in the chat, and I want to see if anyone else has a question for question 4 through 7 before we move on to learning objective 3. Rez is asking whether the modeling to learn is a platform to run system dynamics or a demo. So modeling to learn is our version of the Foreo Epicenter platform that can run under the hood almost any number of system dynamics models. It can run a Python model using completely open source languages. It can run a Vensim model. It can run a Stella model. And you can build on the Epicenter platform completely on your own, or you can consult with them for smaller little consultant packages, or of course they can do a really whiz-bang job for you. In our case, we opted for sort of an in-between approach where we have retired Colonel James Rollins, a contractor with the VA, who has sort of worked with us to tailor our user interface in a participatory way over time with our stakeholders. So he's tailoring that Foreo. And for sustainability, it's real affordable. If you have questions about it, please let me know. We can talk about it more, but it's real affordable to host your stuff on Foreo and make it scale to people who aren't going to have Vensim on their VA machine out in the rural, wherever, or something like that. Any other questions about this? If not, we'll scoop up these questions in the last question break at the end and just cover our last learning objective. Okay, I think maybe we'll just scoot along. You want to take this one, Tom? Thanks for all the questions, by the way.
Sounds good. So objective 3 is to explain how models evaluate causes of implementation outcomes by accounting for complexity, feedback, and changes over time. And honestly, this one is a bit of a trick, right? Because models don't evaluate causes of implementation outcomes, but modelers do. So there's a fundamental aspect of system dynamics, that the model is there to represent the problem, but at the same time, is good, even if you do that, if no one, and you do that really well, if no one uses the model to make new decisions, then it's not going to have any EBP-related impact. So we have to distinguish the causes of EBP implementation problems in the models from the modeling theory of change, which is our intervention when we use models with stakeholders. So now, within the larger field of system dynamics methods, we can think of this as a sort of multi-component implementation strategy comprised of looking at the data and bringing that to light for our frontline staff, the facilitation, and the participatory learning from simulation. And we offer free licensure credit to frontline disciplines to train with us to go through our program. And in this, nothing is added on, rather activities are swapped out or upgraded depending on which team is involved in which part. So we have virtual facilitation designed to maintain our 3 guiding participatory principles. We're always trying to empower frontline teams through the transparent review of their own local data, right? They put all this data into the system, and at least in VA, it's not very common that frontline teams ever get to pull that data back out and make use of it. So that's one. We try to combine the experiential learning to find out what will best improve veterans care locally within their context, within their existing resources. So no theoretical simulation runs about, well, what if we had twice as many staff? And we want to keep decisions about what to do with data focused and on the team trying to come up with improvements that can be shared across all team members.
And Tom, I was chuckling, I'm sorry, there should be 3 bullets that say equitable access to resources, mutual learning, and shared decision-making, but that animation has disappeared. So apologize for that. So we now have 2 parallel arm cluster randomized implementation trials underway, and we're testing 2 possible mechanisms of change that kind of fit this distinction we're making between the formal representation of your modeling problem and its dynamics in the model versus what you're trying to get out of a modeling strategy. Like, how do you think it could actually explain any improvements you see in your primary implementation outcome, or for us, EBP reach? And so up at the top here, you're seeing one hypothesized mechanism we're tracking with our NIH grant, which is that it's the ability for teams to make better EBP-related decisions because they have a better understanding of complexity, feedback, and system behaviors over time. Or it could also be this VA-tested pathway about participatory learning. Maybe teams improve their EBP decision-making because the resources actually better facilitate mutual learning, getting on the same page, shared decision-making and capacity building, or local co-ownership of what gets developed than sort of the imported one-size-fits-all solutions that are common. Of course, we expect that both pathways could be in operation, and what we're doing in our trial is just varying the 2 arms, where they're parallel in every way, same data, same guides, same branding, same facilitators, everything about it is the same, except whether participatory simulation is in there. And so we'll see whether either of these explanatory pathways is significant in predicting the change in our implementation outcome. We're measuring these 2 pathways both in terms of our teams of providers and in terms of in-session fidelity to our theory of change among our facilitators. All right, Tom, we're almost to the end here.
All right, I know we're going to have to step it up.
Rush. Yeah.
So
pause.
Another key question is, how might you and your partners distinguish what is included in the models from what is needed to be accomplished during your modeling sessions? So for us, after working with a lot of different teams over the years, we came up with this 12-session plan that fits into their team's normal sort of huddle period. So the first phase is the partner phase, where we focus on reviewing their local data and developing a strong working alliance with the team, and also identifying their key local needs. So not what's the problem broadly, but what is the problem that the individual team are facing. Then the next third of sessions are what we call the build phase. That's where we build their capacities for participatory learning through modeling. So that's where we're looking at the diagrams, right? Doing a lot of causal loop diagramming and sort of exploring the diagrams, the stock and flow models. And then we have the apply phase, where they get to do those, test their hypotheses in simulation and try to incorporate all the systems thinking skills that they've gained over the whole program into actually making a change in their real world decision making.
So I think at first we wondered if this was going to be more like you model to come up with your local implementation plan, like we all come up with one applied plan at the end. And really what's much more consistent with the decision science frame of system dynamics, and I'm skipping ahead one slide to this, is the ability to better understand complexity, feedback, and system behavior over time is key for all those rule of thumb heuristic decisions providers make all day, every day. And as I've said, as a patient, it terrifies me to think of how constrained decision making is among providers. But when I'm a provider and I have my hat on, I know it's the reality. And so John Sturman, and I really commend his 2006 paper, it's in the reference list if you want to check it out in the American Journal of Public Health. He really talks about the idea that what most of our EBP implementers are doing is making decisions in the real world where we have, missing information, delay, ambiguity, and we form mental models based on that bad information. And that's a real bummer when it comes to the decisions we make. Oops, sorry about that. Where performance is the goal. We don't want to lose a single veteran to relapse or overdose or suicide. And so since no veterans are harmed in the running of a simulation, the virtual world offers significant EBP opportunities for learning for staff, because they can run through all those scenarios they always wondered about and get complete, immediate, accurate feedback about what's likely to happen locally. And so just to kind of make sure we have time to, I know we've taken most of the questions throughout. I love all the questions. Thank you for submitting them. Just consider as we wrap up too, this last question. As you're using these modeling scripts to turn your variables into decisions, always stay really close to what EBP-related decisions those model end users can actually make, meaning they're empowered to make. So we did not, for example, run through a bunch of simulations showing frontline staff that if they just had more money and resources and hired more staff, something that's completely out of their control and completely disempowering, we're not running simulations that are out of sync with the real decisions that are under their purview. And so think very carefully about taking an empowering frame and thinking through who needs these tools to find the best local changes faster. It could be that they're budget making type of decisions, if that's who your model end users are. And in our case, it was really about how to help staff allocate their local time and resources. I think we'll go to the last question, and I'll grab some of the questions that are already in the chat. So this workshop, yes, if you haven't already signed up in advance, we did email this out if we had your email from the conference program committee. Stacy or Jen, do you mind just uploading the file to the chat again for anyone who joined later? And you can also email mtl.info@va.gov, and we'll give you the packet that you may have been filling out as we go along. Why don't we just take this question from the chat first, Tom, and then see if there's any other ones before we get off the line. Have you read it? Limited data, what kind of data would be helpful? I can take it if you're not ready to.
Oh, what type of data would be most helpful to collect?
Maybe I'll take this one first.
Yeah,
if
go
that's
for
okay.
it.
Yeah. We actually had times in our project where we wondered for 6 months whether we had to collect new data or we weren't going to be able to calibrate our model, because staff were debating whether they had data at the right level for their problem or whether there was an existing data source for that. We also had times where the whole project could have ground to a halt thinking about whether the data coding needed to be cleaned up, and it could have been all about cleaning up coding of medical data. So I think that in general, what I would point out if this area is totally new to you is that, like the model we showed earlier, it by definition will calculate variables and structure of your implementation problem based on the data that you do have. So you can see here that we're reading in, read means read in from team data, data that they have about patients who initiate after they start therapy, who complete, and so on. But we're getting more information in the variables that are calculated. And this is something that gets validated during the model calibration phase. So I would say that relative to almost certainly any statistical modeling I've learned over the years, missing data problems are much less of a problem. We also have green what if scenarios here where we don't have data, but people want to experiment with that decision. And so it's probably going to be outside of our scope, Alejandra, to answer that question more thoroughly. But I would say there are some unique aspects of this tradition for addressing sort of the Swiss cheese data problem, where you have data on this, but not something else, because the models can work with that.
Yeah, yeah,
Tom?
definitely. I would say don't let a lack of data hold you back from building your causal loop diagrams with the team and moving towards simulation, because you can always add more detail and more significance to whatever your parameters are later, right? But you can still get a lot of benefit out of doing simulations with the team's best guess at what their new patient start rate is, or what their average patient's duration in their clinic is. You can get a lot from that without going into actually, parameterizing it.
Yeah, and I'll take one more stab at a question. I want to give people permission to move and take a break before your next session. I do want to thank our funders and our team. Point out that there are references with the links to them in the packet and in the slide deck. Remind folks that they can go check out the demonstration model for free. And just also say to Alejandro, in response to Alejandra's question, a different point of entry for those of you writing a D&I grant. I think often what I'm encouraging folks, including some folks on this call, to think through is like, what are you missing in terms of your preliminary data that explains why you think participatory system dynamics might help with your implementation problem? We spent the first third of the questions focused on that. So what I mean by that is sometimes if you're writing, say, like a 2-year R21 or some sort of like smaller scope, maybe the thing that you really need to still get done is to identify your data sources. Or maybe what you really need to show is the feasibility that you can run some group model building sessions. What part of what we covered at the first third of the workshop are you missing that you could do in sort of your pilot project or whatever you need to justify the larger project? And I think that that's another thing to respond to Alejandro with about the missing data is, if you really don't know where the data is going to come from, your reviewers are going to want to see you have a really clear plan for that within the scope of your grant, or preliminary data that shows you can feasibly get that, and you're going to be able to use that data. I'm getting so many encouraging comments. I just want to thank everyone for coming through. Lots of gratitude. Thank you so much to everybody for being here. If you have follow-up questions, there's an email here, mtl.info@va.gov. We'd be happy to take a look at what you filled out in your packet. And I really thank everybody for being here. I hope you have a great rest of your meeting.